Hello and good afternoon. Welcome to this Engaging the Mind program. My name is Susan Lynch, and I am the Associate Director of Lifetime Learning at the University of Virginia's Office of Engagement. And I'm so pleased that you're joining us today to learn about innovations in breast cancer research and treatment at UVA. This program is in partnership with the UVA Cancer Center, so I'd like to thank my colleagues in the UVA Cancer Center Advancement Office for their partnership in developing and promoting today's program. Before starting the program, I want to provide some quick housekeeping items. If you have a question during the presentation, you may enter it in the webinar Q&A at the bottom of the screen. Your questions will only be seen by the panelists and not the larger audience. When submitting your questions, you have the option to send your question anonymously before submitting. You'll find resources in the webinar chat box below. Please also note this program is being recorded and will be posted in Lifetime Learning's podcast library in about a week or two. Please keep in mind that our panelists are unable to answer any personal medical questions or offer any medical advice during this webinar. So now on to our speakers. Dr. David Brenin is the M.C. Wilhelm Professor in Diseases of the Breast and Chief of the Division of Breast and Melanoma Surgical Services at the School of Medicine at the University of Virginia. Dr. Brenin is a fellowship-trained breast surgeon and an expert in surgical procedures involving the breast. His primary research interests include focused ultrasound ablation of breast tumors and immunotherapy. Dr. Brenin is traveling today. At the halfway point of the program, we will share his pre-recorded presentation. However, he will be with us live for the program's Q&A. Our other speaker is Natasha Sheybani, who's an assistant professor of biomedical engineering in the School of Engineering and Applied Sciences, and she also holds a courtesy appointment as an assistant professor of radiology and medical imaging at the University of Virginia. She's also the research director of the UVA-focused Ultrasound Cancer Immunotherapy Center. Professor Sheybani leads a translational research program that innovates tools and paradigms for non-invasive precision cancer management. So thank you again for joining us for this Lifetime Learning program. Now I'm going to turn the program over to Professor Sheybani, who will speak first. So Professor Sheybani, I invite you to turn on your camera and to start your presentation.
Thank you so much for the kind introduction, Susan. And it is really a pleasure to be here and to share with you all a little bit about what our lab and the broader community here at UVA is working on with respect to innovative cancer treatment and research in breast cancer. So as was mentioned, I am an assistant professor of biomedical engineering, and much of the lens through which I view our challenges in cancer management are from an engineering perspective. And what has really been enlightening for me as an engineer is making a foray into the world of immunology. And I suspect that many of you on this call are aware of the profound impact that immunotherapy has been playing as an emerging pillar of cancer treatment. So for those who are unfamiliar, traditional cancer therapies like our radiotherapy or chemotherapies often have this off-target impact whereby in the process of killing cancerous cells, they can also exert impact to healthy cells. And this is where we see a lot of those toxic side effects that are associated with our mainstays of cancer therapy. Alternatively comes the role of immunotherapy, where the idea is that we are effectively unleashing the power of the immune system to combat cancer much in the way that it combats the common cold, with the idea being that when immunotherapies work effectively, they have not only trained our immune cells to identify and combat lesions at a local area in the body, but now those immune cells are also able to recognize cancer at distal sites. And of course, those distal sites are what we refer to as metastasis. One of the other benefits, of course, is that there are fewer, albeit still some side effects that exist with cancer immunotherapy. And the timeline for the emergence of this therapy is shown on the right, where you can see again that surgical debulking, radiation, and chemotherapy, which are often standard of care across a variety of different cancers, have emerged over many a decade ago, and then came the foray into the use of targeted drugs for cancer therapy. And today we sit in this very exciting era of immunotherapy that has now been recognized over the past decade through recognitions like Breakthrough of the Year in Science. This is actually from 2013, so literally 10 years ago. And most recently in 2018, the Nobel Prize was actually given to Dr. James Allison and Dr. Tasuku Honjo, who were really the luminaries that envisioned and ultimately discovered the power of our immunotherapies, and specifically a class known as checkpoint inhibitors. That is really the class of immunotherapies that I'm going to spend a little bit of time talking about today. I'm specifically going to be talking about one of probably so far the most successful and the most widely used modes of immunotherapy, which is through the inhibition of an axis called the PD-1, PD-L1 axis. Basically, the idea is that when T cells interact with tumor cells, which are very good at hijacking our body's endogenous mechanisms and camouflaging themselves, they tell these T cells to basically slow down, to calm down, to not attack the cancer. And the idea behind checkpoint inhibitors is that they can actually break that axis through the use of antibodies that target either PD-1 or PD-L1 and effectively unleash the power of T cells against cancer. And so again, PD-1 as well as PD-L1 blockade have really made waves across many different cancer types. However, there is, of course, a problem, and this is where we as engineers become very excited about what we can do to help. And that is that in the wealth of advancements that have been made, whether that's involved controlling cancer to the point of extending life or even curing cancer in some cases, immunotherapies still sit at around 15 to 40% when it comes to the proportion of patients who respond. And responses can, of course, be variable, and moreover, they are not easy to predict. And those are really two of the challenges that my lab aims to tackle with our approaches. And so the underlying paradigm underscoring the variability has something to do with the figure that I'm showing here. One of the ideas that has long been established for how patients might be predisposed to response to immunotherapy has to do with pre-existing immunity within their tumors. And that's depicted here, where you can basically see that all of this brown staining represents inflammation or the good actors of the immune system already being resident within the tumor at the time that immunotherapy is applied. And as you can see here, we generally suspect that those patients will respond more favorably to immunotherapy. On the other side of this axis sit the non-inflamed tumors, or what we call immunologically ignorant tumors, which are largely devoid of that pre-existing immune infiltrate. And so the challenge really lies herein, where there are patients who just fundamentally don't have the right immunophenotype to be predisposed to response to immunotherapy. And one of our goals has been to push patients from this state of being what we call immunologically cold over to a state of being immunologically hot and hopefully more responsive to immunotherapy. One of the strategies that has emerged for basically pushing patients into the right portion of this axis has been utilization of combinatorial therapies. And I couch this very broadly in that combinations can include multiple different flavors of immunotherapy, the use of radiotherapy or chemotherapy, and more recently, the exciting use of another modality, and this is known as focused ultrasound. And that's actually what I'll be talking about today. So our goal in our lab and through much of our enterprise at UVA has been to basically leverage focused ultrasound in a manner that could potentiate immunotherapy through strategic combinatorial paradigms. And of course, this is with the goal of hopefully ushering more patients and a broader spectrum of patients into the category of being more responsive to immunotherapy. So for those who are unfamiliar, I'm just going to start with a quick primer on what focused ultrasound is. I think many in the audience are likely familiar with diagnostic ultrasound, the general principle whereby we project sound waves into the body and we receive an image back. The idea behind focused ultrasound is that we're basically curving the aperture of that transducer to transmit those sound waves into a single ellipsoid focus. And within that focus, which I would kind of liken to the concept of taking a magnifying glass out on a hot day and basically shining a bunch of rays of light through the glass such that you can burn a hole in a leaf, the idea is that you've projected all of that energy into a single focus. We're doing the same thing with sound waves here. And a lot of interesting things begin to happen within that ellipsoid region of the focus. And I'm going to speak to those in a moment, but I want to preface by saying whether you can kind of visualize this through the analogy or through the image here, that fundamentally what we're doing is applying sound waves in a manner that does not impact intervening tissue, but instead localizes all of the bioeffects to a single region within the body. And this can sort of be anywhere in the body, though the example I'm showing here is brain. A couple things to take away from this are, again, we're using sound waves, therefore this is non-invasive. It's non-ionizing, and also whether in preclinical or clinical studies, this method has now been shown to be safe, repeatable, and of course a major strength is that it's highly localized down to sub-millimeter precision. Now, I mentioned a lot of interesting things can happen at this focus, and that's where there are a tremendous range of mechanisms of action for focused ultrasound. And I'm framing those very broadly to fall across a spectrum of being either thermal or mechanical in nature. And I'm kind of showing snippets of the sound wave here, just so you can picture what the projection of that physical wave looks like, whereby it is either applied in a continuous manner to actually allow heat to accumulate, or we can apply those sound waves in a pulsed manner to actually allow mechanical effects to occur. And within that spectrum of different things that we can do to perturb tissue, in this case, cancer tissue, we can achieve a variety of different things. We can damage and destroy tumor tissue, effectively ablating, whether that's by thermal or mechanical means. We can also improve drug delivery. This has been a particularly important area when it comes to applications within the brain, which can be very challenging for some of our therapeutic mainstays to access effectively. And also in the more recent years, we've discovered that these bioeffects can also bear impact on the immune system, effectively stimulating it. And so part of our lab's goal has been to basically deconvolve these effects and understand how we can come back to that cold to hot paradigm and utilize the stimulatory effects of focused ultrasound to basically potentiate different classes of immunotherapy. And just to paint a slightly broader picture here, I just want to drop in a few words about the global landscape of the field. One being to impress upon this audience that there are quite a few different mechanisms of action for focused ultrasound, and I'm really only scratching the surface today. These range from, again, being tissue destructive to exerting a variety of other bioeffects, including radiosensitization, neuromodulation, sonodynamic therapy. These are all, unfortunately, things that, while we have exciting activity ongoing at UVA related to these themes, we just don't have time to talk about them today. Similarly, there are a number of different clinical indications for FUS today, and I'm really only highlighting a fraction. In fact, because this is a breast cancer webinar, I want to draw your attention specifically to the category of women's health indications, which you can see range in developmental stage all the way from being sort of conceptual or preclinical in the preclinical stages of development, and they range all the way from having undergone clinical trials and even in some cases having received outside or US approvals, which is very exciting. All in all, there are over 170 clinical indications to date for focused ultrasound technology, and this number continues to climb. Finally, something I want to mention is that we're very lucky at UVA to now be home to the world's first focused ultrasound cancer immunotherapy center, which Susan kindly alluded to in her introduction. I'm going to abbreviate this as the FUS CIC. And the idea within our center is that we really have three goals. One fundamentally applies to scientists like myself. Our goal is to discover. And again, that discovery has a whole lot to do with the preface that I provided on where we sense that there may be a role for focused ultrasound to potentiate immunotherapy. However, we are very driven by the mission to help patients. And so fundamentally, much of what we're doing at the bench side is with an eye toward how we can get things to the bedside as quickly and efficiently as possible. So we're very lucky to have a robust translational pipeline here. Very fortunate to have colleagues like Dr. Brenin, who you'll hear from, who are really pioneering to push the work forward in the clinical space. And finally, I think all of this sets up quite nicely to differentiate UVA and to distinguish us as an institution that is making strides in the advancement of focused ultrasound for applications in immuno-oncology. Now, we've been very mindful to sort of generate a bit of thematic integration around a few areas of emphasis. And I'm just sort of encapsulating some of the broader activities that are ongoing that I won't speak to today, like work in pancreatic cancer, melanoma, and brain tumors. But what I will just spend a few minutes talking about now is some of the work that my lab and our collaborators' labs have been doing in the space of breast cancer. So today I'm going to stick with the theme of thermal fuss, with the idea being that we are applying those continuous sound waves that I mentioned before in a focal manner to basically cook or heat up tissue to the point of destruction. And actually, an example of how we do this in our preclinical models is shown here. We're here performing focused ultrasound treatment, so that ablative regimen. You can see a simulation of the heat temperature rise and the focus here. We're performing this ablation under ultrasound imaging guidance. And so each of those points that you see on this hypoechoic or dark region, which is the tumor, is actually a point that is being sonicated. And we're visualizing that in real time, where the interference on the image is actually when the ultrasound therapy transducer is on and treating. Now, as you can appreciate from the sparse nature of the grid that's overlaid on the tumor, our goal here is to perform partial thermal ablation or subtotal ablation, with the idea being that we're trying to preserve a certain degree of tissue that has undergone heat-mediated cell death or damage, with the idea being that it is in those regions where we expect the heightened immunogenic effects to really be fully realized. So on histology, this is what that looks like. The pink regions on this slide basically denote where we have effectively caused coagulative necrosis or burnt the tissue. And you can appreciate that there are other regions of staining that suggest to us that we've indeed performed a subtotal ablation within the tumor. Now, we take this paradigm, and of course, what we did very early on was apply it and sort of look, at face value to what this does in a preclinical model, a highly aggressive model at that, of metastatic breast cancer, more specifically triple negative breast cancer. And what we observed actually was that thermally ablative fuss, much like we see with immunotherapies, does not necessarily do enough to constrain the outgrowth of these tumors. In fact, this is pretty consistent with some of what has been observed clinically, for example, in the case of checkpoint inhibition, where unfortunately the challenge that we're grappling with in breast cancer is that of recalcitrance, where patients are really not necessarily responding to monotherapy. And so the reason I highlight these cases is to highlight the fact that our preclinical models are recapitulating an issue that we see in the clinic and really creating a case for moving to a combinatorial paradigm. Now, of course, the question that we grappled with thereafter was, how do we rationally deploy a combinatorial paradigm to make a dent in these tumors? And so what we had to do, and what I'm skipping over, is a lot of work where we basically had to look under the hood and understand what might actually be creating a barrier to the effective deployment of focused ultrasound and or immunotherapy in this model. And so I'm kind of summarizing that information here with a very a glossary of view of immunology, where I basically couched our effector T cells as our good cells. So these are good players within the immune system. And our immunosuppressive cells, or for those who are interested, myeloid-derived suppressor cells, as the bad actors. And basically what we saw in our breast cancer model was that these tumors were highly laden with the bad guys, or basically the immunosuppressive cells. And these were actually serving as a significant barrier, so we hypothesized, to the effective combination of focused ultrasound with other therapies. And so the first thing that we had to address was this immunosuppressive population. And as it turns out, there's a very nice chemotherapy, gemcitabine, which has a favorable safety and toxicity profile. Some may be familiar with this chemo as a first-line therapy in the context of breast cancer. Pancreatic cancer. You don't often hear about it in breast cancer, but it has been used in palliative settings for breast cancer. And so here we felt it was reasonable to really leverage what is a byproduct of that chemotherapy, and that is myeloreduction, or the idea that basically that chemotherapy could target highly proliferative cells, which happens to be these bad guys, and transiently knock them down. So we apply gemcitabine, and in the process of suppressing the immunosuppressive cells, we hypothesize that we should see open up the gateway or sensitize these tumors to the effects of the good guys, or these effector T cells. And to summarize some of what we observed in deploying this combination, we actually were able to see reduced tumor burden, extend overall survival in the mice, and also we observed in some slightly more mechanistic studies that this effect was dependent specifically on T cells. So all of this was very good news. I want to snapshot through the data for those who maybe are interested in that, just to demonstrate that, again, what we did here was combine focused ultrasound and gemcitabine, our chemotherapy, in a regimen that we understood to be transiently inhibitory when it came to that immunosuppressive cell population I was talking about. And whereas our monotherapies were not necessarily sufficient to promote extensive growth control, we did see this in the context of the combination, and these are representative images of the tumors. And what was perhaps more exciting was that we were able to extend overall survival in a manner that really relied not just on control of the local tumor, but actually on the onset of pulmonary metastasis in these mice. And so one of the final things I'll just note here is that this overall survival benefit, as I mentioned, was underscored by a role of the immune system. And the way that we were able to demonstrate that was basically by abolishing the adaptive immune compartment in our mice, where we observed that in the absence of an intact immune system, the protective effect of the combination was lost. Now, the final thing I want to come back to is the notion of anti-PD-1, which I kind of opened the talk with. The idea at the outset of the data I showed you was that these tumors were not necessarily responsive to PD-1 blockade, but as you can see here, where we sort of left off with this story was to be able to say that combination of focused ultrasound and gemcitabine could effectively sensitize tumors to checkpoint blockade. And indeed, that's what you see here with the gray line. So what all of this has culminated with, I think most excitingly, is a clinical trial. We are now translating, or we have translated, the paradigm involving focused ultrasound and gemcitabine into breast cancer patients, and that is the BR54 trial that Dr. Brenin will be talking about today. This is just an example, again, of how our bench to bedside paradigm looks in practice. So we do have basically an equivalent of the clinical system, our thoracic echo pulse system that is being used to treat patients in the clinic. We're very fortunate to have a research grade analog of that system sitting in the lab that we can actually utilize in our preclinical studies, and some representative ultrasound images are shown here. So coming all the way back to the problem, I hope I've impressed upon you that there are strategies with focused ultrasound that we can utilize to begin to wrangle, if not sort of narrow down, the variability in response to immunotherapy, and hopefully enable more patients to receive the profound benefits of immunotherapy. But there's a second piece, which is the fact that immunotherapies are not easy to predict. And with the few minutes I have left, I'd like to talk about the idea of precision medicine. And some of you may be familiar, or some of you may have undergone cancer care and have probably seen that in some cases, the practice of medicine can still be one size fits all. And of course, cancer is a highly complex disease, and to really bring precision medicine to bear is a very challenging task for that reason. However, the idea behind precision medicine fundamentally is that with the right tools in place, we would have the ability to target the right treatments to the right patients at the right time. And the schematic here kind of shows just in cartoon form what the variability among patients could be. For instance, some patients may respond to normal dose of therapy, some might need less, some might need more, some might need a different therapy altogether. And the long-term vision that my lab is fervently pushing toward is one where we can actually generate the right types of data to then make decisions that would lend to a more strategic deployment of our treatments in the clinic. So this is all to say that this is kind of where we're going next. As far as where my lab is positioned right now, our goal is really to bring non-invasive techniques to bear. And this is obviously motivated by our use of a non-invasive therapy, such as focused ultrasound, in the context of cancer management. And our hope is that we can achieve the ability to really use a precise spatiotemporally tunable device alongside other non-invasive repeatable strategies such as imaging and liquid biopsy, with the ideas being that we can better combine our focused ultrasound, which is highly tunable unto itself, with the milieu, the constellation of different immunotherapies that we have access to. And actually just today, I was reminded that it is Cancer Immunotherapy Month this June. And so the president of AACR, the American Association for Cancer Research, Dr. Greenberg, just recently put this little schematic online where he basically said that these are kind of 4 pillars of what is next in immunotherapy: combination of agents that target independent pathways, advancement of cell therapies, drugs that target inhibitory molecules in the tumor microenvironment, and development of more effective cancer vaccines. And although I'm out of time to talk about all the many reasons why focused ultrasound may have a role to play in each of these 4 pillars, I will just mention that we are very optimistic about the role that focused ultrasound could play in this emerging era of immunotherapy. Much of what we do as a lab is, of course, centered on the bench to bedside paradigm, where we're not only pushing things into the clinic, but learning a lot from clinical trials that have been deployed and sort of using that as a feed forward mechanism for iterating on what we do in the lab. And so just to summarize the pillars that I'm showing here for what our lab does, again, the idea is that we are now breaking away from just combining therapies and trying to think more rationally about how to combine them. And you may ask yourself, well, how do you do that? One of the strategies that we're using as a lab is advanced imaging, things like PET and MR imaging, to basically do longitudinal surveillance of our therapies in real time, and ideally to use that then for pattern recognition within the data that we generate, and also achieve biomarker discovery. And all of those principles apply to the other paradigm that we're following, which is the use of blood draws to basically achieve the same things, but from markers that are resident within the circulation. And finally, while much of what we do as a lab is in breast cancer, that's not the only thing we work on. In addition to extending some of the paradigms that I presented to you today to other FUS regimens, other immunotherapies in breast cancer, we are also working in the brain tumor space as well. And in fact, one of the things that we're interrogating is distal disease in the context of breast cancer, specifically metastasis to the brain. And so with all of that, I would like to thank, all my lab members, all of our collaborators on both the research and clinical side, far too many to name, and of course, all of our funding sources. And I want to thank you all for your kind attention.
Thank you so much, Professor Sheybani, for sharing this very important and interesting research. We very much appreciate your time. As I mentioned in the introduction, Dr. Brennan's presentation has been pre-recorded, so my colleagues will be queuing that up now.
Good afternoon, everyone. My name is Dr. David Brenin, and this afternoon I have the pleasure of speaking to you about focused ultrasound ablation for the treatment of tumors in the breast at the University of Virginia. I have the following disclosure to make. At UVA, we are incredibly lucky to have 2 clinical focused ultrasound devices, the MRI-guided InsightTech Exablade and the ultrasound-guided Theracleon EchoPulse. Our initial experience at the FDA made it clear that the best approach would be to proceed in a stepwise fashion, first treating benign tumors of the breast with focused ultrasound ablation, then moving to treat advanced stage breast cancer, and then finally to treat patients with early stage disease. Moving forward with this stepwise approach, we began by treating fibroadenomas. Fibroadenomas are one of the more common benign tumors of the breast, but they can be quite bothersome to patients, producing a mass in the breast, often causing significant pain and tenderness, and if large enough, they can change the contour of the breast. Fibroadenomas are fibroepithelial tumors, and this is what they look like underneath the microscope. They most commonly occur in women between the ages of 15 and 30. They are usually solitary, but about 15% of the time there can be more than one, and they occasionally occur in both breasts or bilaterally. This is the typical appearance on imaging. On the mammogram, you see a smooth oblong mass, and on ultrasound, a similar appearing lesion which is wider than it is tall and has smooth borders. The typical management of these tumors consists of observation or surgical excision. While fibroadenomas are benign, many patients are quite bothered by them and wish to have them removed. At this time, the most common option is surgery, but transcutaneous ablation has obvious advantages, and at the risk of being too obvious, I'm going to explain them here. This slide has two photographs on it. In both cases, the patient's fibroadenoma is gone. One patient underwent surgery, the other a transcutaneous ablation. Now, no matter how good a surgeon I am, in order to do an operation, I'm going to need to make an incision. And that incision is going to result in a scar. There's nothing I can do to avoid that. So again, in both cases, the patient is no longer able to feel her fibroadenoma. She is no longer bothered by it. But in one case, there's a scar, and the other, there is no scar. And that's the most obvious advantage to transcutaneous ablation, not only to treat benign tumors of the breast, but also to treat all tumors of the breast, including malignancies. Since focused ultrasound ablation is completely non-invasive, it requires no local anesthesia, it's fast. The entire patient treatment experience is typically less than 2 to 2.5 hours, and recovery is quick, usually back to work the day after surgery. We've used the EchoPulse device for all of our breast cancer studies, and it consists of a computer-driven system comprised of an electronics cabinet, an extracorporeal probe mounted on an arm and moved by motors, a cooling unit, and an ultrasound imaging probe that is mounted within the HIFU transducer. Here is the business end of the device. This is the roboticized head. This is a cooling jacket through which cool liquid circulates to keep the skin cold during the treatment. This is the ultrasound probe that is embedded within the HIFU transducer. IDE G130-252 was the first study we did at UVA evaluating the use of focused ultrasound ablation to treat tumors in the breast. It was a single-arm study in which we enrolled 20 patients. The primary objective was to evaluate the feasibility of ultrasound-guided focused ultrasound ablation for the treatment of breast fibroadenomas. We evaluated both tumor response and the patient's experience of the treatment. The primary endpoints for this study were palpability of the lesion at 12 months by both the treating physician and patient, how well the patient tolerated the treatment and their satisfaction with the treatment, and change in tumor volume as measured by physical exam and under ultrasound. We made the above measurements at 3, 6, and 12 months following treatment. Focused ultrasound ablation can be carried out with high precision, but the heat energy of the ablation can be dispersed to the surrounding tissue. As an extra margin of safety, for this study, patients' tumors had to be at least 5 millimeters from the skin and 1 centimeter from an underlying rib. So how is the procedure carried out? The patient is first positioned comfortably on a stretcher, and intravenous conscious sedation is provided throughout the procedure as needed. The mass is then localized with standard ultrasound imaging, and degassed local anesthetic is injected around the tumor. The transducer head is then positioned over the lesion to allow for optimal imaging of the mass, and targeting and treatment planning is performed in multiple planes throughout the lesion. This is what the treatment plan looks like on the device. Here is the fibroadenoma as viewed in cross-section, and here are the sonication zones individually depicted from the side. The treatment head then moves to the next cross-section, and you can see that here. Again, the device suggests multiple sonication zones to treat that cross-section, and these are viewed from the side here. In the middle, we're viewing those sonications from above, and what this is depicting is the entire treatment plan, where we paint sonication zones across the entire tumor in 3 dimensions, thus treating the whole lesion. This is a complete treatment plan as viewed from above, with sonication zones painted across an entire lesion. During the procedure, there are alternating ablation and cooling cycles. Each sonication pulse lasts several seconds, followed by an adequate cooling time, which typically varies between 10 and 25 seconds. The pulse power is first adjusted to create boiling within the tissue in the sonication zone, and then once we determine the adequate pulse power, the treatment progresses until all the sonication sites in the treatment plan have been delivered. So what does it look like? Well, on the device, prior to treatment, the fibroadenoma looks like this. A sonication pulse is then delivered, and this results in a hypoechoic mark as depicted here following the sonication. The treatment head then moves to the next sonication site, and another pulse is given. This heats up the second area in the treatment plan. The device then moves to the third area in the treatment plan. Another sonication pulse is given, and this continues till all of the sites in the treatment plan are sonicated. Following treatment, the lesion usually looks like this. So this is typically what we saw. These are images from our first patient. On the left, you have the pre-treatment ultrasound image with the volume for the fibroadenoma being 1.53 cubic centimeters. 3 months later, after treatment, the volume was down to 0.47 cubic centimeters. That's a 69% reduction in volume. And as it turns out, that was typical for the 20 patients that we treated. And as you can see here, there was a mean percent reduction in volume at 12 months for the 20 patients in that trial of 68.9%. Based on our results, we concluded that focused ultrasound ablation was feasible and effective to treat patients with fibroadenomas. It carried minimal toxicity and was very well tolerated, and we then moved on to opening up a multi-center, multinational trial to treat patients with fibroadenomas with focused ultrasound ablation, in which we'll enroll a total of 100 patients. That study is nearly completed with greater than 95% of patients enrolled, and we hope to conclude that study shortly. Following conclusion of the study, we will move to submit that data to the FDA, which will hopefully result in approval of this treatment in the United States. Okay, so we had some good experience treating benign tumors of the breast. Now it's time to move forward with treating breast cancers at UVA. So I wanted to leverage everything we had going for us at UVA, namely that we have a fantastic multidisciplinary breast cancer program. We have an internationally prominent human immune therapy center headed up by Dr. Craig Slingloff, and we have our clinical focused ultrasound devices. I wanted to leverage all of this, so we decided we were going to move forward by treating breast cancer with a combination of focused ultrasound ablation and immune therapy at our program. Immune therapy leverages the patient's own immune system to help fight their cancer. An important component of immune therapy uses tumor-infiltrating lymphocytes. These are T cells, or a type of white blood cell, that are created by a patient's immune system and can help kill their cancer. In order to be able to do that, the tumor-infiltrating lymphocytes have to be able to traffic to or transport themselves to the tumor. Once they're at the tumor, they need to be able to infiltrate into the tumor and recognize the tumor as not self. The ability to recognize the tumor as not self, or an invader, is vital, because if the tumor infiltrating lymphocytes are not able to do that, they will not attack the tumor cells and kill them. Unfortunately, breast cancer has lots of tricks up its sleeve to fool these tumor infiltrating lymphocytes into thinking that the tumor is self. In other words, it's not an invader, it's not self. One of those tricks uses a protein called PD-L1. This protein normally tells a lymphocyte that a cell is self. Breast cancers can produce PD-L1 and convince tumor infiltrating lymphocytes that it's not cancer, but part of the patient's normal tissue. When PD-L1 is detected by tumor infiltrating lymphocytes, it tamps down the immune response. And for this reason, breast cancers that create PD-L1 fool the patient's immune system into thinking that it's not an invader and it should not kill the cancer. Additional ways that minimally immunogenic cancers can evade immune surveillance and confuse the patient's immune system into not being able to recognize a cancer and fight it include the ability to secrete type 1 interferon. This tamps down the immune response, similar to as I previously described. These tumors can also recruit what are called myeloid-derived suppressor cells and T regulatory cells. These are other types of white blood cells that again have the ability to confuse tumor infiltrating lymphocytes and tamp down that immune response and have the tumor infiltrating lymphocytes not fight the cancer. And then, as I mentioned previously, through the expression of programmed cell death ligand PD-1, which again downregulates the CD8 positive T cells' ability to fight the cancer. Here's a cartoon showing a very tricky breast cancer cell, and unfortunately this is commonly the case. That breast cancer cell is here, and it not only has an antigen for a tumor cell on its surface, but it also makes that antigen PD-L1. Remember, PD-L1 convinces attacking tumor infiltrating lymphocytes, as depicted here, that the tumor isn't a tumor at all, but that it's normal tissue. It's telling this T cell, well, you may have gotten here, you may have detected that something's wrong, but there's really nothing wrong. Just move along. Leave me alone. The way anti-PD-L drugs work is that it blocks that PD-L1 tumor, not allowing it to tell the T cell to leave it alone, resulting in the T cell killing the cancer. Immune therapy has been a real game changer lately and has been very effective to treat patients who have highly immunogenic tumors such as melanoma, lung cancer, and kidney cancer, but has only shown minimal results for tumors that are not very immunogenic like breast cancer, pancreatic cancer, and colon and rectal tumors. We hope that we can treat minimally immunogenic tumors with focused ultrasound ablation and make them more immunogenic. For our first study of focused ultrasound ablation to treat breast cancer at the University of Virginia, we combined focused ultrasound ablation with a drug called pembrolizumab. Pembrolizumab is a programmed cell death 1 inhibitor and has been shown to be effective against treatment of some triple-negative breast cancers, which tend to be more immunogenic, but pembrolizumab is not effective against estrogen receptor positive tumors, which tend to fly under the radar of the patient's immune system. That brings us to our first study at the University of Virginia to treat breast cancer with focused ultrasound ablation, namely Breast 48, which utilized focused ultrasound ablation plus the drug I just mentioned, pembrolizumab, to treat patients with stage 4 breast cancer. The idea behind this is that we know that focused ultrasound ablation can cause an acute thermal injury to the tumor and initiate a brisk local immune response. As part of that immune response, CD8 positive T cells would then traffic to and infiltrate into the damaged area of the tumor, and then we could give pembrolizumab, which could upregulate that local cellular immune response, hopefully resulting in a brisk systemic response as well. The primary objectives of Breast 48 were to assess the adverse event profile of pembrolizumab and focused ultrasound ablation therapy in patients with metastatic stage 4 breast cancer, and to determine whether the addition of pembrolizumab to focused ultrasound ablation increases the proportion of CD8 positive tumor infiltrating lymphocytes into the primary and periablative zone. Stated more simply, the concept behind Breast 48 was as follows. We know that pembrolizumab is able to induce an immune response in some breast tumors, but not most. We also know that focused ultrasound ablation is able to induce an immune response in most tumors, but that local immune response is typically not enough on its own to be curative. And what we were testing was the idea that might the combination of focused ultrasound ablation and pembrolizumab be more effective. This is the schema for that trial, breast 48. In the first arm, or arm A, patients got pembrolizumab after the focused ultrasound ablation, and in arm B, patients got the pembrolizumab prior to focused ultrasound ablation. So like I said, patients to be included in this trial had advanced or stage 4 breast cancer, as well as the other inclusion criteria on this slide. Here are ultrasound images from one of the first breast cancers that we treated. Here's the tumor within the breast. Here's a clip as seen on ultrasound within the cancer. Here is an image from the treatment plan, and as you can see, we delivered focused ultrasound ablation pulses to only within the tumor. We did not treat any of the surrounding tissue. 22 days after the ablation, we biopsied tissue in the peri-ablation zone and tissue from within the ablated region of the tumor. This very busy slide shows a series of photomicrographs. In this column, this is before treatment within the tumor. This is at day 22 in the area of the tumor that we ablated, and this is at day 22 in the peri-ablative zone, in this case still within the tumor itself. They show an increase in the number of CD8 positive T cells that infiltrated into the tumor as compared to pre-treatment, as well as an upregulation of PD-L1 within the tumor, again as compared to pre-treatment. Breast 48 is now completed and closed to accrual, and the final data from that study is currently being analyzed. However, the preliminary data was intriguing, and we've now come to the point where it's time to open a study looking at focused ultrasound ablation to treat patients with early stage breast cancer. That brings us to breast 54, the use of focused ultrasound ablation in combination with gemcitabine to treat patients with early stage breast cancer. This study is currently open and accruing at the University of Virginia. The study has 3 arms. In arm A, patients receive gemcitabine only, followed by standard treatment. In arm B, patients receive focused ultrasound ablation only, followed by standard treatment. And in arm C, the patients receive a combination of both gemcitabine and focused ultrasound ablation, followed by standard treatment. Patients will be followed for 5 years, and tissue will be collected both before and after treatments. Again, we're only treating inside the tumor, and more specifically, the goal is not to treat the entire tumor, certainly no more than 50% of it. Here is a picture of the first specimen from a patient that we treated. This is after treatment, after the tumor has been excised, and you can see there is a necrotic portion of this tumor where we provided focused ultrasound ablation juxtaposed to viable tumor. And again, this is our intent. We're going to obtain biopsies for evaluation of the necrotic area and of this transition area, as well as of the viable tumor. Breast 54 is currently open and accruing patients. We've treated 5 patients to date, and we are using the updated device from Thoracleon, which allows us to treat patients with much smaller tumors. So to wrap things up, at the University of Virginia, we have utilized a stepwise fashion to evaluate the use of focused ultrasound ablation to treat tumors in the breast. We started by treating benign tumors, namely fibroadenomas. We then moved on to treating patients with advanced stage 4 breast cancer with breast 48. And now we're on to our study called breast 54, in which we're evaluating the use of gemcitabine and focused ultrasound ablation to treat patients with early stage breast cancer. We strongly believe that focused ultrasound ablation has the potential to be both a local and systemic therapy, and we will be leveraging that concept in current trials at the University of Virginia, which use focused ultrasound ablation in combination with immune therapy for patients who otherwise would have a very low likelihood of response to immune therapy alone. Finally, I'd like to thank the following organizations and individuals without whom we couldn't make this happen. Thank you for your attention.
So thank you to Dr. Brenin for that information, and I would like to invite both Dr. Brenin and Dr. Sheybani to turn on their cameras and their microphones. So thank you so much. Now we have a few minutes to answer some questions that have come in before and during the presentation. So this question is it's my understanding that immunotherapy does not work for all breast cancer types. And will this therapy apply to many or all types? And what is the potential of expanding these therapies to all patients in the future or near future? Perhaps Dr. Brenin, you could take that one.
Well, as we said in the presentation, the idea behind this is to expand the array of tumors that we can treat with focused ultrasound ablation. As Natasha nicely pointed out, in general, these tumors tend to be either immunologically cold or immunologically hot. The immunologically hot tumors are good to go for immune therapy. Their very nature lends them to that type of treatment. The immunologically cold tumors simply are already flying under the patient's immune system's radar. And the addition of these therapies is usually not enough to get the patient's body's immune system to identify the tumors as not self and attack them to try to cure the patient of the malignancy. With focused ultrasound ablation, we really hope to expand that array with this combination therapy that Natasha talked about, where we combine the local immune response from the injury from focused ultrasound and then ramp up that immune response with these immune therapy agents.
Okay, great. This next question is from a friend of the university. Will this replace disfiguring operations and chemotherapy? And then there was also a question about radiation. So will this replace those things? And perhaps Professor Sheybani could take that first.
Absolutely. So, I'm hard pressed to say that focused ultrasound will be a replacement. I think that, our standard of care therapies are there for a reason. However, I do think that one of the major challenges with radiation and chemotherapy, for instance, is the fact that these do have significant toxicities associated with them. So I kind of view the role of ultrasound as one that is complementary in a manner that could potentially serve to mitigate the off-target toxicities of certain drugs by virtue of allowing more drug to get to the right place and thereby reducing the amount of systemic dose that we need to administer. That's actually true for immunotherapies as well, and mitigating immune-related adverse events. Similarly, on the radiation side, I alluded to this in my talk, but there are those who in breast cancer are looking to certain focused ultrasound regimens for the purposes of radiosensitization. So I think, again, all of these things suggest that focused ultrasound could be a really nice adjunct. In the traditional context that we've long thought about ultrasound, like in the ablative capacity, I do think that there is opportunity yet again for focused ultrasound to serve as an adjunct. And I'm thinking specifically in the cases of malignancy, where you could envision, debulking a tumor prior to complete surgical debulking. And beyond that, in the way of really replacing those things, I might defer to the clinical expertise of Dr. Brenin to say how he, envisions focused ultrasound playing a role.
Well, I'm not sure I'm an expert, but I view this as the natural long progression of the treatment of cancer, and specifically breast cancer. When you look back at the turn of the prior century, the early 1900s, we had a very, very radical operation that was popularized to treat breast cancer, a radical mastectomy. It was a very disfiguring operation, to answer the question that posed more directly. But over time, it took nearly 100 years. But, I'm exaggerating. It took about 70 years to realize that maybe we didn't need to do that operation, that we could do a smaller, less disfiguring operation and remove less of the breast. And then we figured out, well, we can combine another treatment in this multifactorial combination treatment. We can combine surgery with radiation in the form of a lumpectomy and an operation under the arm followed by radiation, and still achieve similar results. Then we started to have good systemic treatments like chemotherapy. So those were combined with surgery and radiation. Now we have focused ultrasound, and I think that that's going to play a role with all of those things as well. And I am a little bit more hopeful that we could be able to eliminate disfiguring surgeries, because really all we're doing with surgery is removing the cancer, or at least the cancer that we know is there. The cancer that we don't know is there, we're treating with radiation therapy and systemic treatments like chemotherapy and immune therapies. I think that if we get to the point where we can lean on those other treatments adequately, we will be able to, if you will, debulk the tumor in the breast with focused ultrasound, kill most of it, and then rely on immune therapy, the patient's immune system, and probably some radiation therapy to the breast, as well as some, hopefully, less cytotoxic chemotherapies to treat breast cancer. That's really my vision, and the vision of the Focused Ultrasound Immune Therapy Center to treat patients with cancer for the future.
Yeah, thank you. And so what are the implications of these advancements for the treatment of metastatic breast cancer?
Natasha, you want to take that?
Okay.
Yeah, I think, maybe I'll sort of paint a broad picture first by coming back to the basic principle of immunotherapy. I think what's so powerful here is that we are really trying to mobilize the immune system to fight cancer. And maybe, the best way for framing that is basically to say that cancer has this really fascinating ability to veil itself from the immune system. And so fundamentally, what each of our different immunotherapies try to do in different targeted ways is lift that veil. And so when that process works effectively, like Dr. Brenin mentioned, it has the potential to not only work effectively at a local site, but also at the sites of metastasis. Unfortunately, in those recalcitrant or immunologically cold tumors, we have this issue of often having patients succumb to metastasis, actually. And the same is true in our preclinical models as well. Often the thing that we are fervently combating is the onset of metastasis. So where does that bring focused ultrasound? Well, I think the same paradigm follows. Basically, where we are able to be effective with focused ultrasound, we are really striving for the goal of being effective against metastasis. And so I absolutely do think that this work bears very important implications for the role of immunotherapy against metastasis, but also I think there are kind of two frameworks through which to view the focused ultrasound component. One is sort of what Dr. Brenin framed quite nicely, which is treating with focused ultrasound and immunotherapy to mobilize activity at the local lesion in order to then mount a systemic response against cancer. Another one that I might offer, and again, I touched on this very briefly at the end, is a situation in which we are actually directly targeting metastasis. And for instance, one way that we're doing that right now is by specifically looking to brain metastasis of breast cancer and thinking about ways that we can actually tackle the cancer at that site of brain metastasis. And so all of that is to basically say the answer to the question is yes. I think there are absolutely important implications, and I'll turn it over to Dr. Brenin in case he has other.
Right. Well, we're coming up on our time, so I wonder if I could just fit one more quick question in. Is that
Sure.
Okay? The question is, how soon will focused ultrasound be available in clinical practice?
So focused ultrasound is currently available in clinical practice to treat cancer, to treat bone metastasis. It's also available to treat non-cancerous conditions, and I'm talking about in the United States now, in the brain. In other parts of the world, it is approved by their corollary of the FDA to treat many types of tumors and benign conditions. We are a few patients away from completing a large trial of using focused ultrasound ablation to treat fibroadenomas in the breast. And I think we need another 3 patients to complete a trial of 100 patients. And we're looking at that as our pivotal trial to go to the FDA once we have those results in the hope of achieving an indication from the FDA to use focused ultrasound ablation to treat benign tumors in the breast. And once we get that under our belt, it really does open up a new world for other treatments in the breast. So in terms of breast tumors, we have no FDA approved indication right now, but we're on the cusp, we hope, of receiving one.
Wonderful. Well, thank you so much to our esteemed speakers. And as you can see, UVA is very lucky to have such skilled researchers and clinicians in our cancer center and our UVA health system working to better the treatment of breast cancer. So I want to thank Dr. Brenin and Professor Sheybani for sharing their knowledge and expertise with all of us this afternoon. Thank you so much. And I also want to take a moment to bring an upcoming Lifetime Learning program to your attention. This Tuesday, June 20th, Lifetime Learning is hosting the second program in this series in partnership with the UVA Cancer Center with a program entitled Prostate Cancer, From Diagnosis to Recovery. This program will explore the controversies, challenges, and opportunities for patients undergoing prostate cancer screening and treatment. To register for this program and to find other Lifetime Learning programs and resources, please go to our website at engagement.virginia.edu/learn. When you are there, you can also check out other Lifetime Learning programs, our podcast library, our Thoughts from the Lawn blogs, and our UVA Speaks podcast series to read, watch, and listen to our expert UVA faculty. So thank you again for joining us for this hour of learning, and I hope you enjoy the rest of your afternoon and evening.